Now, anytime you're dealing with a patient who has some kind of behavioral emergency, you're kind of on a continual reassessment, right? And this doesn't mean that you have to touch the patient again and again and again. This just means that you are continuously and constantly assessing your patient. You're looking for a change in their behavior or a change in their condition. Make sure that you're documenting everything that you possibly can in regards to what they say and how they say it to you. And then, if at all possible, you want to give the receiving facility an early notification that you're coming in with a patient who has this particular crisis happening. Anytime that you have to use some kind of restraint, and for the AEMTs, generally are only allowed to use physical restraints, you have to make sure that you document that. And anytime that you document that you've had somebody restrained or that you actually have to physically restrain a patient, you should probably always have somebody there to witness and assist you in the event that something goes wrong. Now, in this particular slide, we're going to talk about a little bit more about restraints, and we really only want to restrain patients if it's absolutely needed. One of the more degrading things that you can do to a person is to restrain them. So much so that it's kind of fallen out of vogue in most of the systems that are ALS capable, because the chemical sedation seems to be of far more benefit emotionally to patients than having them tied down. And it used to not be thought like that. They were very liberal with the ability to just tie a patient down to a gurney and transport them against their will. And we're finding that that's not really making them very compliant or willing to work with the providers. And so that has now shifted to just kind of give them the ability to take the edge off of them and get them to the place that they need to be so that they are in a calmer state of demeanor and willing to actually operate within the provider's care. Now, obviously, when you're dealing with a patient, from the moment that you come on scene, somebody should be with that particular patient at all times, right? We're never going to let them go into another room to go get something by themselves. Somebody should always be evaluating what's happening, and you should always be with them in the back of the rig, right? This is not a patient that you're going to tie down and go right up front with your partner. You're going to watch and make sure that we're not creating a situation where this patient can have more harm come to them because of our inattentiveness. We never really want to challenge a patient. We're not there to be the aggressor, to agitate them or escalate them. And then we're not trying to cause them any more situations that are going to cause them undue stress, right? And so your job as the AEMT is really just to keep them neutral or give them the ability to feel like somebody cares about their situation and get them to the appropriate place. We're not really going to try to come up with judgments or give them our opinions, right? That's not your job. We're, again, not providers, especially not of behavioral health. So make sure that you're just using compassion and sound judgment when you're dealing with these patients. In the cases of acute psychosis, this is where a patient becomes delusional and they're pretty much what we want to call out of touch with reality. So they may have auditory or visual hallucinations. And some of the causes can be mind-altering substances, right? Think of your methamphetamines, where somebody's been without sleep for 3 and 4 days because they've been on that particular drug bender. Now they're hallucinating from lack of sleep and overstimulation. They could have intense stress, which is causing them the inability to sleep or have these other things going on where it's changing the way that their brain is perceiving inputs. And then delusional disorders, right? These are persons who have something such as schizophrenia, where there are manifestations mentally of things that are not actually happening, and the patient may or may not be aware of that. And while they may tell you, like, hey, I know the devil's not in the room, but the devil's in the room, they're unable to actually disassociate from something that's being chronically pushed into them internally, right? This is not a switch that they can flip on and off. It's in regards to schizophrenia, this is a really complex disorder. It's really hard to treat, and what you guys should know is that a lot of your patients who are dealing with mental health issues are really not compliant with medications for the most part because of the way that the medications make them feel. It's very blunting to them, and they would much rather medicate with something else than to feel like they're kind of blunt or having a lack of affect through day-to-day activities. Also, in schizophrenia, this is something that generally does not occur until patients are probably in their mid-teenage years, and then there are some outside cues that are going on that they think contributes to this, which could be some kind of brain damage, a genetic component where there's a family historical situation where this may be hereditary, and then there are some psychological and outside social influences that may help trigger this. And unfortunately, for the most part, schizophrenia is not something that's really ever cured. This is something that's either maintained with drugs and therapy, or it's left untreated, and these patients suffer for the rest of their life. Again, with the schizophrenia, these people are going to experience delusions, hallucinations. They tend to become withdrawn, and they have lack of interest in things that give them pleasure. They will have erratic or forced speech, and that's because they're having auditory hallucinations as well. And they may have other conversations going on at the exact same time that they're having a conversation with you. And these patients are really, really struggling to kind of maintain focus on what's in front of them, which may be you or a law enforcement officer at the particular given point in time. You're going to have to make sure that you determine whether or not this is a dangerous situation. Are they kind of presenting to you with nonverbal cues that they are extremely agitated and going into survival mode? And then make sure that you're staying calm and very direct, right? And you're going to use your nonverbal cues to let them know that you're not a threat, but that you are also not a prey item if they are going to end up becoming agitated to such a degree that they become violent. You want to make sure that you maintain a little bit of distance with these persons, and this is emotionally, verbally, and physically, and that you're not there to argue with them. You're solely there to provide them with adequate treatment to the appropriate facility. And then explain to them the things that you need to do to complete that particular mission with them today. And then always try to get somebody that the patient trusts or gain the patient's trust yourself by showing them empathy and compassion. So unfortunately, from time to time, we're going to deal with a patient who has suicidal ideations or a suicidal attempt. More often than not, this comes as a result of chronic depression, although some of these patients may actually not present with that depressed state because they've made the decision that they're going to inflict harm, and because of that they have this like sense of resolution to something, and some of the depression appears to have been lifted from them. So it's a common misconception that people who threaten suicide never commit it. In actuality, men will actually complete the suicide attempt and be successful more often than women, although women generally have suicidal ideations more often than men. So suicide is usually a cry for help, and it's one of those situations where we are bound to get that particular person transported to a facility so that they can actually have the help that they need, right? You're never going to leave a suicidal patient on scene or at home, right? If they admit that they have suicidal ideations or they have attempted to harm themselves, at that point it's implied consent because they are not making logical decisions that a normal person would in regards to their personal well-being. So in your book, you're going to see the risk factors for suicide. I'm not going to go through all of these. It's really easy for you guys to kind of look at this, and then you guys can see that if you're looking at these particular things where these triggers or the risk factors, that they're fairly self-explanatory. Some of the warning signs for suicidal ideations are obviously signs and symptoms of pretty significant or severe depression, right? So this is the tearfulness, the sadness, despair, or hopelessness. They tend not to want to make eye contact with you. They're very withdrawn, and they project like a sense of vacancy, meaning that they will speak like they are not any longer part of the society or that particular family, or that exact existence. They tend not to talk about the future because they've already disconnected their place from the future. They have suggestions of suicide, and more often than not, they can actually tell you that they have plans relating to causing death or the things that would come after their death. When you're dealing with somebody who's made the decision to cause self-harm or has attempted, make sure that we're looking for unsafe objects, right? And this is anything that's pointy to something that's a blunt instrument that could be used for striking. And then we're looking for any kind of self-destructive behavior. And as I mentioned before, really this is kind of a younger person or a teen phenomenon with the cutting. If you see many dozens to sometimes hundreds of small light scarring on the extremities, these are signs that that patient is self-destructive and they're causing some kind of physical manifestation of their emotional pain. And you can generally have a consensus of whether or not this patient is a threat to themselves or others based on their verbal and nonverbal cues, and then try to understand whether or not there's an underlying medical problem. A suicidal patient can absolutely, because of just the fact that they are willing to cause harm to themselves, be very willing to cause harm or death to others. In regards to agitated delirium, this is a condition of impairment and cognitive function. They're disoriented. They may have hallucinations or delusions. And again, I usually roll backwards into the methamphetamine abuse, where this person has gone without sleep for 2, 3, sometimes 4 days. And now because of the lack of sleep and the ability to kind of let the brain heal itself, they are having these manifestations of the hallucinations and the agitation, right? These patients are usually going to be characterized by restless behavior, and they're going to have irrational and irregular physical activity. They're going to have jerky, irregular movements and may have considerable tremors to the extremities. These patients may strike out irrationally because they are unable to really kind of process the information that's coming into them from their surroundings. And you should generally consider your personal safety anytime that you're dealing with this patient. And again, this is the kind of patient that may cause themselves further harm by being physically restrained. And we want to make sure that this is one of the last things that we do if we need to. And it's only if they're going to cause themselves harm or you or your partner harm. So some of the symptoms for this agitated delirium are hyperactive, irrational behavior, the inability to pay attention. They may actively be having hallucinations. Generally, they will have some kind of hypertension and tachycardia. They'll be diaphoretic and have dilated pupils. A lot of times, the agitated delirium is due to a stimulant in nature, and that's why you're getting all of those particular symptoms that very much fall in line with sympathomimetics or stimulants. Again, this is where we really want to be calm, and you want to approach the patient slowly and make sure that you're letting them have their territory, limit your physical contact. So we never want to leave these patients unattended. We never want to let them leave the room alone. Don't give them the opportunity to create an even more dangerous situation by having them retrieve something that can be turned into a weapon or harm themselves. We're always going to try to deal with agitated delirium patients by trying to figure out exactly where they are on the alert and oriented scale. Like, these patients are generally awake, but they may not actually be oriented to person, time, or place, and they may not have very good judgment-making skills, which is a more reliable indicator of their cognitive function. Don't get caught into the A&O times 4 trap as a means of you assessing whether or not they're able to make good rational or clinical judgments of their care. Pay attention to the patient's ability to communicate, what they appear to be like, and their personal hygiene. Are these people taking care of themselves in what would be considered a societal norm? And if they're not, what is the causation of that? Is this a acute phenomenon, or is this something that's long-term and we're dealing with something a little bit differently? Again, on the restraints, if you're going to make sure that you have a patient restrained physically, you want to have adequate personnel to help you. The last thing that you need is a patient who starts to degrade because they're being restrained. If your patient has some kind of chemical overdose as part of the causation of agitated delirium, make sure that you take anything that you have to the medical facility so that you can help them identify the offending agent. So remember that there's legal considerations anytime that you're dealing with a patient who ultimately ends up having to be restrained. At a certain point, you're technically violating their rights, and this is because they're clinically unable to make good rational decisions for themselves. And so you can lessen the problems when patients consent to care instead of going into the physical route to initiate transports. Make sure that you're trying to gain their confidence and their trust, and likewise, right? Like they should be gaining your trust as well, so that there's a mutual expectation that the two of you will behave appropriately to get them the care that they actually need. If they are mentally incapable of making decisions, that means that they're unresponsive or they are clinically unable to make rational decisions, then that patient may require immediate medical care, and they may actually still resist your attempt to provide that care, but you can always have law enforcement kind of help you out with this, and they can ride in with you and help you keep that patient restrained, whether that be by soft restraints or handcuffs. Generally, the idea is to keep them in soft restraints so that if they do fight against the restraint system, that they're not causing more harm to themselves. Any patient who is unable to give consent due to their current state of cognition is going to be transported with the implied consent, assuming that a patient who is medically competent would absolutely give you the consent to treat them. This is going to fall underneath the emergency doctrine, and if you're questioning this at all, you're going to make sure that you request the assistance of law enforcement personnel, and try to remember that you have a limited legal authority to require a patient to undergo medical care. If there's no absolute life threat, then it's really hard for you to force that transport. The thing that we want to do is try to determine whether or not they are a threat to themselves or other persons, and does their inability to make a competent decision alter their right to refuse care. Now, when we get into psychiatric cases, just remember that in the court of law, we're going to determine whether or not this is psychiatric. So in this slide, this is saying a patient who is impaired in any way may not be considered a competent patient. Now, what that does not mean is that, like perhaps you have a patient who has had 1 or 2 drinks of alcohol. That does not mean that they are no longer competent to make their own medical decisions. So again, this really comes down to your ability to ask pertinent questions and understand whether or not this patient actually has the cognitive function to make a competent decision. You may not violate their legal rights if they are able to choose and make rational thoughts regarding their care. Now, we do always want to err on the side of treatment and transport whenever possible. And again, if this is one of those situations where you have a patient who is really insistent that they not be transported, but they are unable to make a good, solid clinical decision, you may have to involve law enforcement in this, and always get your medical control involved in this, right? This is the MSEP consult where you're conveying what's happening on scene to help get a physician to absolutely demand that they are transported against their will. I'm not going to get too deep into the legal actions. Again, the idea is not to restrain patients unless they are absolutely a threat to themselves or others. They are always well within their rights if they're able to make a good, solid judgments, regardless of whether or not you agree with them or not. If they choose to not seek further treatment and they're rational, that's the end of the story. Anytime that you put your hands on a patient without their permission, you are technically going to be considered to have battered them, and then the threat of restraining or performing actions on a patient is assault, And if we tie a patient down or we transport them against their will, that's called false imprisonment. And all of these are a violation of basic civil rights. So I'm going to kind of breeze through the rest of the restraint portion on this, because I think we've kind of touched on this enough that you understand that restraints should be a last course of action, and really just to keep the patient from causing any harm to themselves or you or your partners, and only so much as to actually just get them to the place where they're going to need help. So it should always be one of the last things that you do anytime that you're trying to get somebody to go to the hospital. I mean, this should be not taken lightly, and we should really be doing everything that we possibly can to get compliance without force. As always, if you guys have any questions, the appropriate way to deal with that is to either send me an email or engage in discussion in the lab portion of class. Again, I want everybody to remember that there are significant psychological components to many of the calls that we go to, and as you get deeper into your career, you're going to start to see these underlying factors. I encourage everybody to take a course or 3 on psychological issues. There's plenty to learn about the everyday interactions that we have with other human beings, and the classes will only actually help you kind of communicate with these persons in a more effective manner, which will make your job a lot easier in the long run.